My guest today is John Zutter, CEO of Lantern, the specialty care platform serving 12 million people across the country. If you're an employer paying for healthcare right now, the scariest line item on your budget isn't primary care or pharmacy. It's specialty care, surgery, cancer, infusion therapy. It's the primary driver of healthcare costs, and for the employee on the other side, it means navigating a major surgery or cancer diagnosis with no idea which provider is good and what it will cost. The company started in 2011 and now connects members to thousands of specialists at over 500 facilities with a complication rate under 1% against a national average of 8 to 15. In March, Lantern closed a $30 million investment led by Morgan Health, which is JPMorgan Chase's healthcare division, and Echo Health Ventures. John is a former JPMorgan banker who joined in 2016 and grew the company from 100,000 members into one of the largest players in employer-sponsored specialty care. John, it's amazing to have you on the show, so thank you for being here today.
Yeah, thanks for having me.
Yeah, so kind of going through your background, it's so interesting. You come from investment banking, and then you kind of started your own kind of, you were a co-founding partner of Dundon Capital or something like that. So you definitely did not come from healthcare based on my experience. I wanted to kind of first start off with someone in your end coming from not a healthcare background. What was it like coming into the space at first? What was the knowledge gap and what did you have to learn? Because it's a complicating space.
Yeah, no, it's interesting. So I had started my career, as you noted, doing financial services, investment banking. And then I went to industry and then was on the investing side. And so when I got to healthcare, I didn't have any healthcare experience, but I found that there were a few things that were common in financials versus healthcare. You've got highly regulated environments, state and federal. You've got incredibly sensitive information. On the one side, you've got personal financial information. On the other side, you have personal health information. A lot of similar kind of dynamics around how you have to be thoughtful around that. You had some similar complexities with respect to how data gets transferred. So in financial services, for example, often there are many kind of steps along the journey from a financial product, starting with a customer and then going to capital markets. And the steps in between that has a lot of kind of big data translation and interpretation that it's not terribly distinct or different from the way in which large data sets have to be moved around healthcare, where like how do you accept data from one place and then send it to another and everyone actually understands what they're looking at. So there's a number of similarities in terms of that complexity that exists across both of those. So that's like the similar part. The different part is just about everything else, right? And so, I had come from working at a large organization, JPMorgan, to running a very small and early stage growth business. The operational dynamics, the people dynamics, the customer dynamics, just about everything else was extremely different. And we kind of had to learn as we go. We got a lot of bumps and bruises along the way.
Yeah. Kind of going into Lantern specifically, you built the business from kind of 100,000 members to 12 million-ish. So very, very fast. It's crazy the expansion that you kind of built with the employers that you've worked with and the amount of employees that are benefiting from specialty care practice. What was actually broken when you started? And what was the first thing that you were trying to fix?
So when I first took the seat in December of 16, we did a little bit of a retrospective. We had lost 50% of our clients in the previous 6 months. Mm-hmm. So not the greatest seat to step into. And so you have to ask yourself, like, why is everyone so displeased with your offering? And it's pretty unique in the employer space to get fired in the middle of the year. Happened a lot. And what I found is that probably the biggest thematic one, it's kind of a first principles thing that applies to all businesses, which is like, if you aren't able to deliver on the expectations you set for your clients, they're going to be disappointed. And so broken expectations was probably the biggest thematic one. And that came from a lot of different sources from an origination perspective, communication gaps, analytical gaps, operational gaps. But at the end of the day, we had set a series of expectations of what we could deliver for our clients.
Right.
And we ultimately, you hear that beeping?
Yeah, that was mine. That was my side. I apologize.
Yeah. Sorry, I want to make sure it wasn't something over here.
No, yeah.
So we set a series of expectations for our clients, and back then we weren't consistently delivering against those. So the first and most important thing was understanding why and what was the kind of root causes of those expectation mismatches, and then trying to prioritize against those and deliver against mitigating those issues. A lot of it really stemmed from internal communications. We weren't a large organization. There was like 15 employees at the time, but believe it or not, even though they were all in the same office, they didn't talk to each other. And
Mm.
so you had a sales team that would communicate with a client about a set of expectations, an implementation team that wasn't clued in on that, that would then help to implement that client, an account management team that wasn't part of the implementation or the sale, and then a network team that wasn't talking to anybody. Getting people just on the same page around what is the client looking for and how are we all going to kind of unify and deliver against that is probably the biggest turning point for us.
Interesting. I mean, the original, I guess, COE or Center of Excellence, I guess, playbook was, like kind of like that Walmart style, and something that you actually talked about, which was something that actually doesn't work. Fly the employee to like a large health system like Mayo, and then, I don't know, pay a bundle, save money. Like worked on paper, but utilization was actually terrible. And that's something that you kind of mentioned. What was the kind of consensus, and when did you realize the entire industry was, I guess, kind of like centered against the wrong model, and kind of like actually take the offering local care was like the best kind of
Yeah.
method in general?
So I often credit this with there's a school district in southern Houston, or excuse me, in southern Texas, outside of Houston, or part of Houston, I guess, that was looking at our services. And their people are all clustered in that part of southern Texas, and they were trying to solve a problem of variability in costs, variability in quality, just cost being too high, accessibility issues. But you know, the story of go to the name brand institutes that you just mentioned didn't solve their use case, and so they were pretty clear that it was we want our people to get great quality care, but our people live here, and so that's probably the first one where we actually started referring to ourselves as a surgeons of excellence model.
Yeah.
We also we looked at the analysis and they said, well, how do you deliver on that problem? Like, how do you deliver superior quality care, superior utilization uh, across more things in more places? Well, the only way you can do that is to be more granular in your selection criteria.
Mm.
And so it was probably both the ask from the client that was more tailored, but then saying, well, like, how do you respond to that ask? And the only way you can actually deliver against that ask is to be much more granular in your analytics, much more granular in your selection criteria, much more granular in how you think about the healthcare economics side of it. And once you do that, that actually unlocks a much more scalable model because it works just about everywhere.
Interesting, interesting. So how was it easy kind of like scaling that model overall? Because kind of working with, going kind of like the local first is kind of hard. The brand names aren't there, the Hopkins, Cleveland Clinic. You have to kind of independently assess all of these individual people, these, for example, surgeons in a community setting. How did you kind of scale that model from from one location to the next, and I guess follow
So
on?
I think this is kind of a unique thing about two-sided networks relative to some of the purely virtual care or other digital health solutions. Digital health solutions are almost by definition geographically scalable, right? They aren't geographically specific, and so that allows you to go to clients that have membership bases on a highly distributed basis and serve them.
Right.
And so typically when you look at like the employer digital health growth continuum, almost everybody follows a similar playbook, which is you have a founder, you find the right kind of go to market team, you find the right investor, you start with some large clients,
Right.
you expand amongst the large clients, and then you go down market over time. And you see that with almost all in our space. We had the kind of the reciprocal of that, which is you started in a smaller market segment and worked up. And I think we might have done that by accident, but upon reflection, it's actually probably the only way you can solve the network problem because you can't go to a really large employer that is in hundreds of markets if you aren't already in hundreds of markets, right? They don't have enough bandwidth to do pilots in every different market they're in. And so you have to be able to be serving the overwhelming majority of that client, or at least a very material slice of it. So we started with a propensity towards like call it 1,000 to 5,000 employee groups. And that's pretty distinct for most digital health companies that start much larger and work their way down. And I think that's probably the only way you can do it because when you're in that size bucket, you have a much higher concentration index And so you're going to find manufacturers that have 3,500 people in this one market, or a professional services business that has 5,000 people in this one market, or 2,000 people in that one market. A school district's a perfect example. They had about 10,000 people all in one county. And that means that the two-sided network can be solved more completely, more simply. So, school district in one county, you have one client, you now need one set of providers.
Right.
Because you don't need to solve their problem everywhere in the country. You need to solve their problem in one place. And so you kind of start with clusters. Smaller clients gives you the ability to have two-sided network adequacy, and then you expand clustered, and it a little bit feeds on itself. So we had an oil and gas client in 2015-16 where, we had started in Texas, in some of the big markets in Texas, and they were based in Houston. We were able to serve them in Houston, and they said, we also have a big population up in Tulsa. And so, okay, great. So we have enough critical mass to serve a big enough of your population, and an opportunity to then build out the next one. Then from there, you get a client that's in Tulsa, but also in Oklahoma City. And you build that second one, and then suddenly you're in 5 markets, and that means you can fill gaps more effectively. So that's kind of the bottoms up approach. The top down, that's kind of from our genesis, was a realization that something like 82% of the US population lives within an hour of one of the top 50 metropolitan statistical areas or top metropolitan markets. And so if you're within an hour, that's kind of a reasonable distance that people are willing to go for a major medical event. Like, I'm willing to drive an hour if I'm going to have a spine procedure. Like, I wouldn't think twice about that if it's going to be more affordable, higher quality, etc. Whereas I might not get on a plane for 5 or 6 hours, right? And so that's kind of a key jump. And so the top-down strategy was be in the top 50 markets, and the bottom-up was let your go-to-market kind of drive that of where you go next.
Interesting. Do you recommend early stage founders to also kind of go with the approach of this two-side network if they're going for the employer strategy of kind of going for their employees or school districts, do you recommend going for that like super big brand name heavy? Like, how do you suggest startups to kind of go with that methodology?
I think it's very much got to be product specific, right? And so you want to take the approach that maximizes your probability of success, maximizes product market fit, maximizes your ability to kind of explore. As an early stage business, you don't necessarily know the perfect direction, so you got to have a little bit of room to maneuver. I think the reason you see most digital health companies start big is for 2 reasons. One, with a digital only solution, you can serve those markets, and you can serve bigger markets, and therefore, like, you have more opportunities to win with less kind of statistical aberrations based on the demographics that you might find with a smaller client. So that's one, makes it more like extractable. Second, your cost to acquire on a digital one might be different, right? And so, like, if you have a solution that is one that can be offered virtually, then you should start big. If you have a solution that is possible to be offered virtually, it's probably going to be complementary to other more brick and mortar distribution channels. So, like, health plans are anchored around networks, right?
Right.
And the virtual solutions that were really innovative over the last 10 years were offering a complementary capability that the health plan or the PBM or another convening agent might not have had. And so that gave kind of a go-to-market momentum, kind of turbocharged for those sort of business models. So they had kind of 2 benefits, right? Which is like their solution can go without geographic constraints, and their solution is one that is complementary to large distribution channels. So those are like 2 really strong amplification engines that are part of the reason that a lot of those have been quite successful. I think the two-sided network is actually a really hard one. It's a really hard one to get off the ground because of all the things I just mentioned around you need to be matching both sides of the network in parallel as you grow, and where you grow is not perfectly predictable. And so you're going to have variability in performance based on things that are not totally in your control. But from like a Helmer's Powers perspective, like, it's a more persistent moat over time. Like, scale effects and network effects is more persistent, probably because it's harder to find success in. But once you found success, it's harder to replicate.
Interesting. There's an interesting stat that I saw about you guys that your members run like a very, very low complication rate compared to the national average, which I believe is around 8 to 12%. How did you guys kind of come about that over time? Because I'm assuming at the beginning it wasn't really less than 1%, but you guys were maybe below the average. How did you guys get to that specific very low complication rate?
Yeah, no, it's a great question. There's a simple answer. We asked the experts.
Fair enough.
So, but this is actually a pretty nuanced difference versus some other quality approaches that folks in healthcare have taken. Some have taken kind of a top down big data approach and said, like, how do you analyze all the data to find the answer? And there are ways to certainly be effective on that. We started with a different approach. The data wasn't quite as accessible back then, certainly more so now. I think today the right answer is both, but we went to great specialists in each category and asked them a pretty simple question. Like, who would you refer to? And how would you make that decision? Like, what would be the standards for you to evaluate a peer? And if you go to a really great spine doctor, top of their specialty, and you say, who are the great ones? They'll rattle off some names. That's not particularly scalable. If you say, like, what are the criteria that makes you really great or that you would want for someone to operate on your friends, your family, they'll say they have to be doing the following 10 things. Like, these are
Yeah,
clear markers of someone who's doing the right patterns and the wrong patterns. And so, like, that was kind of the starting point, is go ask the experts.
I
And
see.
over time, that's obviously become much more proprietary and customized and nuanced. But in each category that we have, it starts with really an evaluation led by experts in that category of how would they assess their peers.
Interesting. I think one thing that could potentially come about, and maybe you already experienced this, was potential skeptics kind of saying you're cherry picking healthy patients, and that's how you're getting the data. You're finding the best patients, and that's how you're getting the specific information of the less than 1% complication. How do you kind of answer that specifically?
Yeah, well, it's a great question. It has been asked, and I'd answer it in a few ways. One is look at the data and do a risk stratification. What you actually find is, on average, compared to those who don't use us from a similar population, those that do are older, generally lower income. Those two factors alone correlate with risk factors, right? For a variety of reasons. But when you find that you're statistically significantly finding an older population and a less advantaged population, you get ones with higher comorbidities as well. And so we actually, we don't positively select in terms of the retrospective analysis. We negatively select. The other is to just look at the business model, which is to say we don't select patients, they select us. So we do communications to the entire population of all of our clients saying, we're available, here's what we do. Clients call us. We don't turn down patients, right? We don't medically manage, right? Our job is to connect patients to great providers. The
Right.
providers then determine the course of care, and what's appropriate or not appropriate. But two things. One is you look in hindsight, and we have a higher risk population that uses us. And two is our business model is not one where selection is part of our business.
Interesting. When it comes to that specifically, what kind of variables, and you kind of were talking about the variables, do you guys specifically look for the risk stratification overall when it comes to obviously age, and maybe it's not just what you guys are looking for, but naturally the employees are. What is that range kind of look like, and what is it kind of looking over time as we continue?
So there's a number of different indicators that can inform risk, right? So we get medical records for all of the members that are proceeding through journeys with us. And there are things like, what's their blood sugar, their hemoglobin A1C levels, and what's their BMI, and, what are some of their other kind of core health indicators. So, like, there's those kind of obvious ones. You can look at their past medical history for procedural events or chronic conditions or comorbidities. So you look at all those things, and then you look at sort of the socioeconomic indicators, which have to do with money, they have to do with access, they have to do with geography. And so there's a variety of different things that can inform that. In terms of like trends we see in our business over time, I would probably wager that things have not changed that dramatically, but we've probably moved over time as our book has matured to have a slightly higher, like, we started out overwhelmingly blue collar
Okay.
in our population base just because of the clients that we attracted early. And now we probably reflect national averages much more. Right? We probably look much more just like the US population writ large, whereas we probably started out with much more of a manufacturing, retail, industrial bent to it.
That makes sense. I kind of want to go into like the employer health spend specifically. And I think it's very interesting that a lot of, I guess, like the biggest 50% of spend when it comes to the health in most of these businesses is cancer, infusions, and,
And
there's
surgery.
surgery. Exactly. Yeah. And that's over 50%. And it's very curious to me when I was looking into it. Why are a lot of people focusing on the other 50%, and there's not much research or not that much going into the specific three that were listed? Is there any
Yeah.
why?
But the other really big one is specialty drug.
Yeah.
And a lot of people are focused on that, right? There's tons of strategies around that and people doing good work around how to contain those costs. And there's a bunch of reasons why that keeps growing, which we could talk about separately. But the three that we focus on that sit within the health plan side, I think, first of all, there is a tremendous amount of focus on them. If you look at the National Business Group on Health survey of large employers and where their top priorities are, I think the overwhelming majority of them list both MSK and surgery, as well as oncology in their top 3 or 4 priorities and have for the last couple of years. So I think it is a really big focus area.
No, I meant like it sounds like it is definitely a focus area, but I felt like a lot of founders and a lot of focus in those specific categories when maybe building specific solutions.
Well, maybe I think I'll give 2 answers to that. So, like, let's take MSK as an example. If you're going to try and support cost containment in MSK, you can kind of think about the before and after of a procedure, like virtual physical therapy as an example. And you've got Hinge, you've got Sword, you've got some others in there that have pretty strong offerings and very strong product market fit and strong client bases and strong funding. And you can think about the actual provision of care. And you've got folks like ourselves and a couple of others that again are, I think, in a pretty good market position, good growth, good client bases, good results, good funding. And you could think about the diagnostic side of it, like imaging, and there's a number there, like One Imaging or Covera, similar dynamics. So I think it might be, if you're talking about why are you not seeing the entrance of more early stage founders, it might be because there are established kind of scale up growth companies that are doing pretty well that make the barrier to entry pretty hard. Like
That
if you were to try and enter the virtual MSK space right now, like I'd advise you to look at the couple of really strong players there and question whether that would be a good use of your time.
Mhm.
And I think the same thing on the network side, where we talked earlier about how hard it is to create two-sided networks and how
Right.
persistent they are from a moat perspective. Uh, Starting one from scratch is pretty hard.
Yeah, that's true. And I think you guys specifically started off at surgery and you guys created a solution around that. And it's interesting because surgery is very procedural based. There's a bundle and you go in as a physician and there's a clear ending. But then in 2022, you guys launched a cancer solution, which is interesting because obviously cancer is very different. I would say arguably more emotionally devastating for the patient. The longitudinal, obviously very unpredictable because it can come back.
Yeah,
And
more complex.
and what was the exact playbook that you had to change from going from surgery to cancer, and what kind of stayed the same?
Yeah, and it's a great question. So the observations that we had, like we've always had this heuristic of evaluating whether we should get into a new market. And for us, it's low frequency, high severity health events. So like the things that don't happen that often, but they're really big events. There has to be a variability in cost and quality. We have to think it's impactable, at least like in our opinion. It has to be material dollars in aggregate, right? So that has to really matter to the client base. And then the last one is kind of our right to win. It had to require some degree of in-person fulfillment, like around the actual provision of care. That's not to say that virtual things aren't valuable. It's that there are other people that do a really good job at that. And one of our kind of proprietary capabilities is that we've developed a pretty good understanding of how to evaluate specialists and how to figure out who's really good at their craft. So those are our kind of 5-part heuristics. And if you think about that and you kind of just go through categories of care and say what checks those 5 boxes and what doesn't, like surgery obviously checks all of them.
Right.
And a bunch of other things that you'd say, well, what else could you get into? Don't, right?
Interesting. Yeah.
And so like broad-based navigation, there's a lot of value to be had from that. It's a category others have focused on. It's not really our right to win. Virtual MSK, it's adjacent to us, but it's not our right to win, right? There are others that can do that better. And that's why we've partnered with others like Hinge Health. And so when you go through that, cancer squarely says yes to all of those questions. It is very low frequency. It's about 1.2% of a population on an annual incidence rate. It is definitely high severity, emotional and financial. It's large aggregate dollars for a client. It's typically 15 to 30% of spend, depending on their demographics, and it's growing really fast. It 100% requires in-person fulfillment. Like, you have to go see doctors for a variety of reasons. And there's huge variability in cost and quality. So it checked all of our boxes, and that was kind of the first thing. Second was that there's like a dearth of solutions out there that were really impacting the problem. And so we thought our knowledge of how do you identify great providers, it hitting kind of our right to win checklist and our heuristic and the market need created a unique opportunity. And I think that's part of the reason we've been able to grow it to, well over 1 million people on the platform right now that have access to that and growing pretty substantially year over year.
Interesting. I think one of the interesting things you brought up is partnerships. You recently partnered, or I guess not recently, but you partnered with a interesting, I guess, cancer center at the Access Hope. And that kind of got me kind of interested into like, why specifically did you partner with them? Kind of like, you brought up Hinge, you partner with Hinge as well. Why did you want to go into the partnership category for them versus just building a solution? And I kind of wanted to wonder, what is your specific strategy for the build versus, I guess, buy strategy solution in general?
Yeah, no, good question. So Access Hope started out doing kind of traditional expert medical opinions. And over time, they pivoted largely to focus on what they call APOs, or advanced precision oncology, where they're working with someone's treating physician to enable that physician with the expertise that comes from some of the top cancer institutes around the country. So very much it's a provider-driven engagement modality. We had been building a member-based engagement modality based on a care team led by highly experienced oncology nurses and supported by others, where we were reaching out to the member and helping them through their journey. Access Hope was reaching out to the provider. And so it was a kind of a complementary engagement modality where 1 + 1 = more than 2. Mm-hmm. We were good at something that they hadn't built out. They were good at something we hadn't built out. Like, I think they probably could have tried to do our thing. We could have tried to do their thing, but instead we each try and do our thing really well. And it turns out that we can bring something to the market that's even more robust and more differentiated.
Right. Interesting. And I guess kind of in that trend, I guess infusion was your most recent expansion in 2024, I believe. And you've, I guess, negotiated at the individual drug level across sites of care and to get savings upward to like 50%, I guess, in my notes. So site of care and I guess arbitrage and infusion is one of the most, lucrative. How did you kind of, I guess, for example, on yourself, you never seen a hospital. How did you, or in like through your background, how did you kind of get into the, I guess, rhythm of saying, okay, this is super important and we need to kind of get characterized in here?
Yeah, so it kind of goes back to that same heuristic of frequency, severity, aggregate dollars, variability in cost, impactability,
Right.
and in-person fulfillment. And so it checked all those boxes again with infusions generally between 5 and 10% of spend, growing really fast. And so we spent about 6 months exploring the marketplace and seeing, where is there opportunity to be more efficient. What we found was that there was actually a substantial opportunity to go and do that. And it was very akin to surgery. It is itself like episodic. It's episodic and often recurrent, right? And so that's a distinguishing factor relative to surgery. Like, you're not supposed to get a knee replacement every quarter. Some people get infusions, for a condition that they have that's a chronic condition on an ongoing basis, every quarter, every month, every year, whatever it might be. So there are some nuances, but a lot of it were pretty similar. Like leveraging, we're a TPA by licensure, so we can go and do direct contracts. We can pay those contracts, hold them ourselves, and adjudicate those payments. So a lot of it was highly overlapping. To us, it was less of a new product and more just an additional service line to Lantern Specialty Network, where, within Lantern Specialty Networks, there's orthopedics, there's spine, there's women's health, there's gastrointestinal, and infusions followed a very similar business model with simply being an additional service line that we could offer to people and expand the value proposition.
Interesting. I think kind of going into the employer side of things, I've spoken to so many employers over my, I guess, time so far. And one of the biggest things that they've kind of said is that there's so many point solutions that they've worked with and they never get any accountability a lot of the time. And I think it's interesting because you've positioned Lantern as this, I guess, platform consolidating specialty care into literally one contract, I guess more literally kind of horizontally. Where I was kind of curious is when does like platform consolidation serve the buyer and when does it specifically could not really serve them and just be an extra, I guess, invoice to them?
Yeah. So it's a really interesting question. Clients are looking for simplicity, but above simplicity, they're looking for outcomes. And so there's a tenuous balance there between trying to provide them with one size fits all to all of their problems,
Right.
and thinking you can do that better than the health plans. And I'd argue you probably can't. Or being really narrow and trying to be a specialist at what you do and delivering and executing against that value proposition. We've tried to stay pretty focused in what we do. We do partner with those that are adjacent, if it's able to either enhance our offering or theirs or reduce contracting friction. But as a general rule, we've tried to stay incredibly focused in our narrow lane and just be the best at that compared to, anyone else in our space. I think that's a different model. Like there are some others in our marketplace where they're taking the opposite path of saying if they can support more and more of the kind of various problems that the buyer has, like they're better positioned. I just tend to disagree that I think over time, the ability to deliver outcomes is going to be based on your execution. And so staying focused is going to be your differentiator.
Yeah. And I think it's a very interesting kind of thought process there. Kind of you mentioned being differentiated is one of the biggest things. And I think that kind of correlates into like the exact point of like how these employers are and I think you've kind of mentioned this as well, where like a lot of employers spend so much per year, maybe like 15 million a year for healthcare. And it's such a big detriment to their organization and they have to close like 16 million to even break even or like so like they're spending a lot and they have to make a lot in sales just to even coop for the healthcare that they're doing. I'm curious like what the conversation is like when you're speaking to like a CEO of an organization versus maybe like a VP of finance or like a CFO. What are the specific kind of things that they're looking for and what are things that they're potentially ignoring or potentially things that they're maybe emphasizing more in these conversations?
I think most executives, whether it's a head of benefits, CHRO, a head of finance, the CEO, I think at the end of the day, they want to make sure that their people have access to the care that they need, but they're also trying to balance that against a line item that in general is their second largest expense line item and the fastest growing one. And so that's the balance people are trying to find. I think there's this dynamic where healthcare is intensely personal and people want to ensure that their employees and their families continue to have the choices that they want to make, but they have to set that against constraints of affordability and access. So I think there's always that balance. There tend to be a couple of different cohorts or like personas. When we think about the client base, there is those that have real margin problem, right? Like their company has a like rapidly growing healthcare costs and you can't pass on more costs to your employees. Like that string's been pulled. And so they've got to be more aggressive and dramatic with their choices. And they might think about narrowing networks, limiting choice, making things required. You have another kind of persona, which is they want to give people a better pathway, but maybe they want to do so with a lesser touch. And in that case, you're going to see a lot of communication, but on a voluntary basis where people can pick, which path they want to go. And here's door A and here's door B. And then there's a third where there are the really impassioned executive teams who know just how variable quality can be and just how expensive healthcare can be. And they, really want to shepherd their employee base and their employees' families to the best possible care, the care that they would seek for themselves. But for a different reason, you often see mandatory or more structured utilization pathways as well. So I think clients fall into a couple of different buckets. the one unifying thing is executives tend to really care about the outcomes that their employees are able to find in their healthcare journeys. And then the balance of kind of paternalistic shepherding versus financially oriented versus quality oriented tends to be a balance based on the business.
Yeah, and it's very interesting. When I was doing my research, you guys literally published so much, right? Especially like last year, you guys published a lot on different methodologies, benchmarks, outliers, and things like that. And I was wondering, like, is this something that your potential competitors could use? Like, did you guys ever think about thought about like your competitors could potentially use your data for other things for themselves to potentially grow? Or
Yeah, I mean, I think that we've never thought that understanding healthcare economics is supposed to be proprietary. Like you're referring to last year when we went open source with our savings and bundling methodology, and I think it's pretty hard to analyze big claims data sets for such a nuanced category. We
yeah,
spent years trying to become proficient at it. And we don't think that's the thing that differentiates us. So we wanted to make that just available to everybody and like poke holes in it. Where are we wrong? And if all of our competitors used it and all of our clients used it, like, and if it's helpful to them, great. I think where we try and differentiate ourselves is in our execution
yeah.
and being accountable to outcomes, not debating, whether a number's right or wrong. Right. I think that should just be binary. It's yes or it's no. And then what we're debating is, can we execute effectively? Can we do what we say we're going to do?
Absolutely. Yeah. And I think that's a great strategy, kind of open sourcing it and kind of just putting it out there to make sure.
It neutralizes it.
Yeah, it does. It really does. And I was like, this is genius, specifically because then you're not, as you mentioned, saying this is one of our biggest kind of things that we care about. What we care about is execution and actually making an impact to the employers that we work with. Kind of like overall, it doesn't really matter if we have this quote unquote proprietary information. So I really like that right when I was thinking about it. One thing that's I think very curious on my end though is that a lot of vendors and buyers, I guess, are seeing so many different potential solutions that can help. What do you think buyers should be kind of focusing on and demanding to see from all these vendors that they're constantly getting pitched on and stuff like that?
Details, right? It's really easy to have a slick sounding story that plays to all the buzzwords of the day. It's a lot harder to show results. They should ask for results. They should ask for details. I think the clients that go deep, and put that time in to really understand the choices that they're making they're gonna make more informed choices. So it's in their interest to do that. I think it says something that like our win rate is dramatically higher for the clients that do more robust analysis. Like it is highly correlated with how deep they go and how high we win. And I think that speaks to just results and outcomes.
Right. I think this might be a juicy question, but going to the previous topic, you've also called on, I guess, the rest of the industry to also publish those methodologies. Has anyone followed up? And what does that kind of tell? Like, and if and has others hadn't? Like, what was like the response when you said, look, this has to be open source?
So we got a lot of really great industry feedback from adjacent partners, we got feedback from healthcare organizations like the Peterson Health Technology Institute and Kaiser Foundation and academics at major institutions like Hopkins and others. We got feedback from most of the consulting houses. We actually solicited it before we even went open source. We haven't heard a thing from either of our competitors, nor have we seen them do something similar. And I'd leave it to them to explain why. But
Yeah.
we did get a lot of really great feedback from industry participants as we were putting that out.
If you had to guess why the data is not really coming out from your competitors, why do you think it's like something? I mean, it's something that could easily be done, right? Like why do you think it's something that they are neglecting or not, or potentially pushing away?
Yeah, I mean, I don't want to speak too much about my competitors, but like maybe they agree with our methodology. Who knows? You'd have to ask them.
Yeah, I think this, kind of going into the specialty care kind of category, which is obviously kind of as we were talking about, kind of getting category competitive with a lot of different players. What is like, I guess, the specific layer that you guys are kind of betting on, maybe 35 years from now, that a lot of the potential competitors now aren't? More specifically, when it comes to when it comes to AI, and I guess the follow on for that is, what are your buyers and vendors looking for when it comes to AI specifically?
So again, I don't know that I have a great view on what we're doing that our competitors aren't. I don't want to speak on behalf of their strategies. What I can tell you is that our efforts are entirely based on trying to advance the value drivers we've always viewed as our kind of North Stars, which is how do you improve quality, how do you improve cost, and how do you improve experience? I think, that last one is where, the prospect of AI, I think is the most revolutionary in that it affords the ability to provide hyper personalization on incredible degrees of complexity and permutation that we
Right.
have to deal with every day. So, like every time a member calls in, you don't know exactly what's going to be their problem or their unique situation. And when you go through all the different things we cover and all the different places we cover, the different degrees of complexity and the different degrees of plan design, those permutations get to a degree that, without generative tools, it's hard to be as personalized as I think the member deserves. And so we see a lot of opportunity to really meet people in that. I think to your second part of your question of like, what is the employer expecting? They are expecting you to deliver on the value prop you sold them on originally, right? Savings, outcomes, experience. They aren't expecting you to put in place AI solutions that are going to allow you to, cut costs without it commensurately improving the member experience. Like they don't care about your profitability. They don't care about your back office stuff. What they care about is, does your product work? Does it work smoothly? Does it deliver on the value prop to the members? And does it do so in a way that is smooth for their administration? So I think you got to stay focused on those kind of front end value delivery mechanisms. Not certainly where we're most focused. I think there's also some degree of nervousness. And I don't think this is unique to our clients or unique to healthcare, but like what does AI mean in terms of your experience like in society and with services, and whether that's healthcare or any other industry? I think things are changing pretty rapidly, and degree that creates a degree of apprehension both for our buyers and for our members. And so I think what that ultimately leads to is that there's going to be a variety of different ways that people want to engage, and that's no different than it was yesterday. It's just the rate of change is different. So some people like to engage digitally, and some people like to engage telephonically, and some people like to engage asynchronously. And I think our job is to be able to afford people the opportunity to engage in the modality that's best for them, but with a degree of personalization that hasn't been possible before.
Interesting. I think one thing when it comes to AI specifically, and I'm curious your thoughts on it, is, I think especially in your case, finding the member before they've already, for example, picked a surgeon or a specialty practice is very difficult to do, and I think it's harder than most people think. How has, I guess, how easily can you, I guess, intervene, and how can AI be used in this specific
So
situation?
we're doing that today. So for about 6 million of our, maybe 7 million of our 12 million member lives, we are using predictive analytics to proactively reach out to people in a more timely fashion rather than, in yesteryear where it was more in a blast generically and hope people call us when they need to. So we've been, very proactively growing that part of our business. The degrees to which AI helps, they vary based on procedure type, like how much predictability there actually is to it. But I think it's going to fundamentally change the way that we engage with members over time, where, my guess is in a relatively short period of time measured in years, that like the overwhelming majority of our engagements are based on predictive outreach rather than based off, any more generic thing. And I think that actually it just means people get less spam, right? They get less non personalized content and they can be more focused on the things that are relevant to them. I think most benefits leaders are looking to say, I don't want to send something about cardiovascular issues to everyone. I don't want to send something about MSK to everyone. I don't want to send something about hypertension to everyone. I want to send the things that are relevant to those specific people in their times of need. And I think, that's really what we're focused on.
Yeah, I mean, you made the point earlier that healthcare is kind of shifting from procedural now therapeutic. For example, now it's GLP-1s. It could be another drug class later. And then at one point, cell and gene therapy revolutionizing a space with with AI and things like that. How is Lantern going to specifically change over time with the changing demands from employees? And how is that going to kind of look as everything kind of rapidly changes?
Yeah, I think we try and keep our ears open about the things that are over the horizon.
Right.
And a lot of our product strategy is informed by not just where today's pain points are, but where we think tomorrow's going. We got into the infusion space, in part for those same reasons, right? A lot of therapies are being delivered through different modalities and less procedural care and more therapeutic care. And that's just one example of that.
Right.
We have a partnership with one of our largest clients, Fortune 50 client in the cell and gene therapy space, as an example where helping them navigate some of those emerging extremely large cost claims events and making sure people get the care they need at the right time at the right place, and navigating some of the most complex journeys. So I think we'll continue to evolve around where we think it's going. And some of that, on our cancer offering is around guiding people in a virtual fashion through like those complex journeys nationwide. And some of that will be around in-place procedural care. And that's kind of the basis of Lantern Specialty Networks as core product one, and Lantern Specialty Care as dealing with some of those complex conditions, namely cancer today, but over time could expand from there.
Yeah. Two more questions before we go into a quick rapid fire here. You know, when I was looking at Lantern a lot, I really thought, at first you guys could potentially go into the payer infrastructure route and work with payers and, work with their members to find the best care. I mean, and then, slowly when I learned you guys are strictly mostly employer, I was like, I was immediately in my mind, I was thinking, can you guys, or have you guys ever thought of going into the payer infrastructure and working with them completely to the point where their members can get a lot of care, or maybe you guys already are? Has that thought process already ever came up in Lantern?
Yeah, so we started partnering with health plans about 36 months ago. Last year, about half of our new clients were actually contracted through health plan partners. And we work with a number of the largest health plans around the country where their clients can access our services through their broader relationship with those health plans. So it's very much a big part of our business. I'd say in the last 24 months in particular, the nature of those relationships has gone from kind of early and figuring out where and how we could work together to being, extremely collaborative and extremely important as parts of our business.
Interesting. What has payers, these guys have told you about the vendors that they're working with and maybe the potential, I don't want to say screw ups, but like what vendors have told them that they could do, but they haven't really done what they could have done. If that makes sense.
You mean what have payers experimented with unsuccessfully?
Yes, exactly. Exactly.
I think the payers are actually pretty good at a lot of things. The breadth of the services that they bring to bear, if we were to try and contract and give as much choice in as many places, I don't think we could do it any better than they do. And that's something that a lot of employers and a lot of members want.
Yeah.
I think where they have probably not been quite as good, and I think are increasingly partnering, is on the hyper specialized things. So it's really hard to build new products as part of a really large organization. And as a smaller organization, it's easier to be more nimble. And so I think that's part of the reason you've seen partnerships really grow as a part of their business, bringing innovation to their large client base, where, some have probably tried to build a lot of things themselves with varying degrees of success. And in certain categories, I think you're starting to see them say, like, the partners are the best way to bring the highest value to the table.
Final question before the rapid fire. What is like one non-consensus bet that you kind of hold about the future of specialty care that most people would probably push back on?
Interesting. I'm not sure that this is purely contrarian, but I'm not sure that I think that there are tremendous benefits from GLP-1s, but I suspect that we're going to find that there are a bunch of pretty broad-based consequences that were unintended that will lead to new issues to be solved. And I think people are probably already working on a lot of those things. But, I think that a lot of folks are maybe thinking it's a simpler solution to a really complex problem. and it might be solving a symptom of the problem, but not the problem at its source. And so there's a broader kind of, how do we make people really healthy? And there's a lot about nutrition and wellness around that. And I'm not sure we're at the source of the problem yet.
Interesting. Okay, quick rapid fire here. Are you ready? Yeah. So, what is a specific metric that you track obsessively that most probably other healthcare CEOs could potentially ignore or not really putting down much attention to?
Various rates of, I would say, utilization rates specific or like broadly,
Yeah.
and mid-funnel conversion rates in particular.
Interesting. So kind of piggybacking on that, why specifically are you really focused on those metrics right now for your employers?
Ultimately, clients care about outcomes. And if you can't activate the membership base, and if you can't then retain them through your journey, then you won't deliver any value.
Interesting. Next question. A widely held belief in employer-sponsored healthcare that's pretty wrong. Like, what do you think in employer-sponsored healthcare that's potentially wrong belief, etc.?
I don't know that we can solve a lot of problems without, like, there is a provider shortage problem, and I think people have thought about telemedicine and about direct primary care and alternative primary care models as a solution. And I think the scarcity problem can't be solved without AI. And so there's a broader use case for AI in solving scarcity of healthcare.
Interesting. Next question is like, what do health systems still not understand about networks of excellence?
I think that health systems have often misunderstood the degree to which accessibility and affordability are critical at the member level. And the balance of those two things is sometimes off in how they're thinking about their own population base.
Right.
Said differently, a health system often thinks of its patient base as like somewhat proprietary without appreciation for just how much affordability is a problem for those same groups of folks, and the need to introduce market forces to solve that problem is really important to that population.
Final set, or two more here. Finish sentence. In 5 years, specialty care will be blank.
The most important category in helping the U.S. fix its healthcare system.
Yeah. What is the final question now, best piece of advice that you have ever received that you did not listen to?
Get more sleep.
That's a good one. But dude, this is amazing. Thank you for being here. I enjoyed this so much.
Yeah, my pleasure. Thanks for having me.